Thank you. So the talk is divided into two parts. One is the state of the field of the computational pathology, and second would be given by Maxime, which is a specific use case that we have been working on morphomolecular classification. So let's begin with my part. The contents of the presentation are organized as follows. So first of all, I will say, why did we go from pathology to digital pathology? Then what are the general tasks at hand for a pathologist? And we want to solve these tasks using machine learning. So before we go into that, I will give an introduction to the machine learning field. And then I will show us a few examples of how we can solve these tasks using machine learning, and then the present and the future directions of where the field is going. So let's begin. So we basically went from glass slides to digital slides, and glass slides are physical slides, right? So why did we really do that? We did that because we wanted better retrieval and sharing of the data, right, of the information. And why we did that? Because we wanted opinion from other experts on a specific use case. Yeah, this opened many doors for machine learning researchers because of the vast amount of data that is generated and digitized, right? So just to be clear, the idea is not to replace pathologists, but to make their life easier and be assistive. And how can we do this? By automating a lot of redundant, time-consuming tasks for pathologists, and also help in the discovery of novel biomarkers. So pathology images are usually H&E images. These are thin tissue sections, and H&E stands for hematoxin and eosine staining. So what the purple staining is usually, so you see that the images are pink and blue. So pink or blue is right, purple. So it's like it stains the nucleus. And then we have pink staining, which stains the stroma and the membrane. And the way we digitize them is by storing, by saving the images in multiple resolutions. And why we do this is because when a pathologist makes a diagnosis, he or she looks into different resolutions by zooming in and out. So that's exactly how we wanted to save it. So for example, here, it's a thin tissue section of probably a biopsy. And then we have access to different levels of information. So like the global structures and the local and the fine-grained cell information, for example. And this data set is very large, like one image can be very large. So it can be as large as 100K cross 100K pixels in its highest resolution. Yes, so let's talk about the tasks at hand for a pathologist. So I will be give an example of prostate adenocarcinoma and bottom-up approach, which means we go from cells, like the smallest feature. So a pathologist, he detects the cells and does cell typing for those cells. And why is it important? Because cells, the nuclear features in the cells are predictive of the survival and grading of cancer. So for example, counting of mitotic cell is an important feature, right? Then we go at the bigger structures, which are glands. And then the pathologist can detect these, needs to detect these glands and segment them. And why do we want to, why is gland an important information? So for example, for prostate adenocarcinoma, when we want to give a Gleason score, which is an indicator of the proliferation. So if the glands are small and uniform, they're well differentiated, and it's a low-grade cancer. Whereas if they're poorly differentiated, and then it's a high-grade cancer. So that's why the shape and structure of gland is an important morphological features for, say, prostate cancer diagnosis. And at the highest global level, we have the tissue. So we're interested in the grading of the tissue, in locating the tumor regions, and this will help us in overall Gleason score grading of prostate cancer, for example. So, a pathologist also needs to provide predictive and prognostic indicators for disease progression. And we know that image features are associated with survival. So for example, we just saw that the tumor proliferation, example, the Gleason score in prostate cancer. Then we have image analysis of immunohistochemistry. These are images where we stain the images with specific antigens, and that help us in diagnosis and prognosis. But as we saw, that a pathologist has many tasks at hand, and some of these tasks are repetitive and time-consuming. So how can we really assist pathologists? By making machines work for them. So before we really make machines work for them, I want to tell you what machine learning is. So there are two types of machine learning. It's supervised and unsupervised. I mean, there are many types, but broadly classified. So in supervised learning, we have the ground truth known, and we have a paired data set. So for example, we have images of cats and dogs, and we have and we want to predict the correct output. So we want to make our network learn that based on this image, what is the output? And we have many labeled data set, right? So using this labeled data set, we learn these connections of different layers that we are seeing here. The other class is unsupervised learning. This is when we don't have the ground truth known for our case. And this is very interesting for pathology because there is a huge lag of annotated samples because it takes a lot of time to annotate them. So one model that is generally used for unsupervised learning is autoencoders. So what is done is, for example, we have an input tile or a small region of an image, and we encode it in a smaller representation, such that when we use this representation, we can reproduce this image. So we want this latent representation to be really good, that is representative of this input image. And when we have this lower dimensional representation of our images, and we take many images, then we can cluster them, and then basically we can group different images and can maybe identify important features. Yes, so now that we have learned about machine learning, what task at hand that we saw for pathologists, what task can we really solve using these machine learning methods? So for example, in bottom-up approach, we saw cell detection and classification. So there is a model, it's called HoverNet. And why we want to do cell detection, we already saw, because it's an important feature for predicting of survival and grading of cancer. So this is the output from from the HoverNet model. So what we give to the model is a part of the image, and then not only detects the cells, it also classifies them into important cell types. And this is a classic example of supervised learning, where we have the image, we have the data, we train our model, and in the end, it segments out a cell and also classifies them. Another example is tumor detection and localization. So for example, what we have is this whole slide images, right? And then we have these annotations of specific regions that are tumorous from a pathologist. And what we do is basically, as I mentioned, that these images can be large. So we subsample them or tile them. And the tiles that come from these tumor regions are labeled as tumor, and the rest are non-tumorous. And then we use a magic for using the CNNs, convolutional neural networks, and then we can train a model that tries to distinguish between the tumor and the normal sample. So where is the field going, right? Where is the present and where is the future? So we really want to translate our methods into clinical practice, right? But it's not that easy. It's not that easy because we need a lot of clinical certification and validation process. We really want to test it in a real world setting. Therefore, we want to work on models that are generalizable, and a lot of research has been going in that direction. Next is the trust, right? So, okay, we work on these models, they're out there, but can we really use them in a clinical practice? In order to gain trust, we want our models to be interpretable. And one of the ways is by attention mechanism. For example, here you see a tissue, and these are the predictions from the model. And the highlighted regions in red are the regions where a model pays most attention to. So with the attention mechanism, we can see what features our model is focusing on when making a prediction. But there is another class of learning. It's called causality. So there's a classic example of. So just to be clear, correlation does not imply causation. And for the example, what we have here is the correlation of the chocolate consumption and the number of Nobel laureates per 10 million population. And we see Switzerland is here. I mean, okay, there are a few Nobel laureates, but, and this shows that if you really want more Nobel laureates in the country, you should consume more chocolate. But come on, is that really the case? So it's not the case, right? So what we want to say is that correlation does not imply causation. And there's a lot of research that is going on in this field. And next is the acceptance of these models by the medical experts. So we want to make it clear that the intention is to be assistive and not as a replacement. And there's also research going in that direction. Now, in the last years, we also have increasing computational power. We have a lot of GPUs where we can do a lot of computations. And this has helped us process really large data set. And it also has helped us in aiding multimodal learning and multimodal data integration. So for example, with our pathology images, we can also add radiology data set and genomics data set. And the next is the discovery of novel biomarkers. So this is really helpful in personalized healthcare. And the specific use case is morphomolecular pathology, which will be presented by Maxime Lafarge. And here what we will show is that we can predict the molecular subtypes using only H&E images and how we integrate in the clinical practice. Yes. So I will stop the share and I will ask Maxime to maybe share the screen.
Sure. Yeah, thank you, Sonali, for this great presentation. So I will continue, and I'm going to share my screen now. Okay. Hello, everyone. Thank you, Stephanie, earlier for the introduction, and thank you for having us today. So now that Sonali has given you an overview of the field of computational pathology, today I would like to present you a use case that our group has been working on, which consists of a classification pipeline that uses two types of machine learning application in the continuity of the topics that Sonali has just presented. So in this presentation, I will go through and present you how we developed this method, validated it, and how in the future it could be integrated into clinical practice. So first, I would like to introduce you the context of this use case. So in precision medicine, it is essential to collect as much information as possible about the state of a disease, such that a clinician can assess the prognosis of cancer patients and decide for an optimal treatment plan. So this is typically done by collecting as much information as possible. So from general information about the patient, but it is also routinely done to analyze tissue samples under microscope, where a pathologist is going to classify and categorize the tissue sample by defining what cancer type it is, by finding specific biomarkers to give it a grade and establish the status of the margins. But molecular testing is also another option, as there exist well-validated molecular markers that can be detected and can help clinicians to adapt and choose the optimal treatment. So for instance, the overexpression of the ERBB2 gene in breast cancer will indicate a resistance to specific drugs. So by collecting all this information, clinicians can make a decision for the best possible treatment. But today, for this use case, I would like to talk to you about a very specific type of molecular marker. So in recent years, 6 independent research groups have agreed and established 4 subtypes for colorectal cancer patients. So this subtype can be identified from RNA data, making it possible to associate every patient to one of these subtypes. And what is important with these subtypes is that each of them is associated to a specific prognosis. For instance, CMS1, which is more immune-rich case, will have a favorable outcome for patients. In the opposite half, CMS4 groups, which are more aggressive tumor types. And the good thing with those markers is that they are associated to specific pathways that are consist of targetable alterations for which there might be optimal treatments. So the problem we have been focusing on is about this question. Is it possible to identify those CMS groups defined on quantified gene expression from raw image data from tissue imaging? So if we can have molecular information from molecular testing, what is the point of predicting those from image data? So there are a few motivation points. So the first one is that this could be used as a complement of, as an extra validation of existing molecular tests. and those molecular tests sometimes fail. So it's always better than having nothing if it's possible to have an equivalent prediction from the image data. Another point is the fact that H&E stain whole slide images are quite inexpensive to produce in comparison to complex molecular tests. And this is a solution to prioritize cases. And on top of that, finding such relationship is an optimal way to find correlation between the morphological phenotypes and genotypical information. And by localizing and finding this relationship, this could give new insights for future research. So to summarize, the goal of our project is to find an algorithm that takes a raw whole slide image as input and then predict the desired subtypes the patient will belong if we will do the molecular test. So typically, the state-of-the-art approach would be to have a machine learning pipeline to model this function and make the prediction. So we address this problem with a two-stage pipeline. So the first stage of the pipeline is to identify the tumor bed. So not only the image, the region associated to tumor samples, but also the microenvironment. This is a very tedious and time-consuming task to do, especially on very large cohorts. Therefore, wanted to investigate whether it was possible to automatize this task with a machine learning model. This is important because this can first accelerate the process for the analysis of the tissue sample, and also to exclude healthy tissue that is uninformative and could bias the model. Then in the second part, we will feed this extracted tumor region to a second machine learning model that will then make the prediction. So for the tumor segmentation task, this was addressed with a supervised learning approach, meaning that we use a data set with paired raw images and tumor annotations that were created by an expert pathologist. And by feeding this model, we are able to make prediction on new images as in a real world scenario. And we validated this on an external test set of with ground truth annotation made by a pathologist. And we had, as a result, a reasonable score, making this integration possible. So for the second task, we also used a supervised learning approach, meaning that we had image data associated with the subtype that is derived from the molecular information. And here we had a similar approach in which we want to make the prediction using a deep learning model from an input image. So because one of the challenge is the fact that those images are too large to be processed in one time, it was necessary to first simplify the problem by subdividing those whole slide images in smaller tiles for which we can make a prediction, and then aggregate those predictions at the slide level in order to make a classification call for the whole slide and thus for the patient. So I would like to show you some results of this classification process. So we show that on a large cohort that by cross-validation that we could have good scores showing that it is possible to reasonably distinguish between these patients related to the molecular information, but using only image data. We also validated this on an external multi-cohort dataset, TCGA, to validate that our model is can still perform in very different conditions than with the data that was used to train it. And here I would like to show you some visualization. Since the predictions are made at the tile level, we can then map them over an image and get an insight into how those model makes prediction and where the information comes from. So here you have an example where the model predicts two subtypes over the image, CMS1 and CMS2. And in order to make a prediction. So what is interesting with this tile-level mapping is that we can also investigate what type of morphologies were used to make a prediction. And in an original study on this topic, pathologists were able to confirm the existence of very specific patterns associated to those classes that they were familiar with, but that they didn't know that those patterns could be associated to those subtypes. So here's another example in which the prediction make majority predictions for the second class CMS2. Here, an example where the predictions are made for the CMS3 class. And here, you can see that those predictions are very heterogeneous, sometimes where you have two classes that are not overlapping, giving new insight about how this information is localized in situ. And here another example for the CMS4. We also validated this task on a small data set, which consists now on biopsy images. And the fact that this type of solution can be applied on preoperative samples has other impact, as it can better support the decision for the treatment plan. Here are some examples of visualization on biopsy samples. So to close the loop, here I would like to show you how this type of tool could be integrated into clinical practice, as those deep learning models can now be integrated directly in existing platforms, making the use of those tools usable by pathologists in the context that they are familiar with. So to conclude, I hope I was able to show you that machine learning models are able to solve clinically relevant tasks, as it can help to support and automate automatous tedious tasks, such as the segmentation of tumor regions, but it also enables to classify complex markers from image data as it was not possible before. On top of that, I showed you that those tools can also help a better understanding of the underlying biology of those diseases via visualization, and that the ongoing integration and validation of such model into clinical practice in existing software promises is encouraging for the future of cancer patient care. So on behalf of Sonali and myself, we would like to thank our colleagues who supported us in the preparation of this presentation. And if you are more interested about the project we are working on, I invite you to check the website of our group or to contact us by email. Thank you.